Hello, everyone. Good afternoon. Thank you for coming. Thank you to Dr. Batty for the introduction, and thank you to the Women's Auxiliary for putting on this wonderful event. I am going to take some time to introduce our panelists, but I just wanted to say it's Breast Cancer Awareness Month. But Breast Cancer Action Month is what we like to call it. We're here to raise awareness, share knowledge, and support one another as we are stronger together. So we're going to join in a conversation together. We're going to have our panelists, our expert panelists. We've got some great speakers for you today to answer some questions. And if we have time at the end, we'll also go to the audience for questions as well. So I'm going to get started with introductions. Bear with us. They're talented. So first is our surgical oncologist, or breast surgical oncologist, Dr. Alex Deal. So Dr. Alex Deal joined Atlanta Breast Care 5 years ago. He has already been included in Atlanta Magazine and Castle Connolly top doctors lists. He's board certified by American Board of Surgery and a member of the American Society of Breast Surgeons, as well as a fellow of the American College of Surgeons. He earned his undergraduate degree from the University of Illinois and his medical degree from Emory. He continued on to complete his internship, his general surgery residency, and his breast surgical oncology fellowship at Emory as well. In addition to his clinical duties at Piedmont, he serves as the chair of the Operating Room Satisfaction Committee. Dr. Deal grew up Dr. Deal grew up in a southern town in Illinois, but he currently lives in Buckhead with his two very spoiled rescue dogs. Dr. Rajni Sinha attended medical school. She's our medical oncologist. She attended medical school at St. George's Medical School in London. She completed her internship and residency at Pennsylvania Hospital, the University of Pennsylvania Health System, and a clinical fellowship in hematology oncology at Emory University. After caring for patients in a busy practice in Chattanooga, Dr. Sinha returned to Atlanta and joined Piedmont Cancer Institute in 2016. She is a member of the American Hematology Society and a clinical research training institute, which focuses on clinical training design and implementation. She also facilitates the breast cancer support group at PCI. Welcome, Dr. Sinha. Next is Dr. Grace Ma. Dr. Grace Ma received her undergraduate degree in biology from MIT. She graduated from NYU School of Medicine and then completed her general surgery residency at NYU's Department of Surgery. Dr. Ma completed a second residency in plastic reconstructive and maxillofacial surgery at Emory University. She is double board certified by the American Board of Plastic Surgery and by the American Board of Surgery. Dr. Ma also completed a 2-year fellowship in surgical oncology at the National Cancer Institute. As a breast cancer survivor herself, breast reconstruction is near and dear to her heart, comprising over 80% of her practice. In 2022, Dr. Ma celebrated the 20th anniversary of her private practice, Peachtree Plastic Surgery, and she currently serves as the section chief of the Division of Plastic Surgery here at Piedmont Atlanta Hospital. Next is Dr. Erin Cook. Dr. Cook is a board-certified breast imaging radiologist with nearly 10 years of experience. Dr. Cook completed her radiology residency and fellowship at the University of Florida College of Medicine and served on faculty for 5 years. She joined Radiology Associates of Atlanta and Piedmont Atlanta Hospital in 2020 and is currently the director of breast imaging at the Dor Shaheen Breast Center. Dr. Cook works with a passionate team of physicians, technologists, and staff, some of whom are here today, to provide exemplary care using the latest technology. Shana Komar. Shana is our registered and licensed dietitian based in Atlanta, Georgia. She completed her undergraduate degree in nutrition, foods, and exercise at Virginia Tech and her dietetic internship at Johns Hopkins Hospital in Baltimore, Maryland. She has been specializing in oncology nutrition for 20 years in Atlanta. In 2006, she helped create and start the nutrition department of the Thomas F. Chapman Cancer Wellness Center here at Piedmont, Atlanta. She currently still works there and provides individual nutrition, counseling, cooking classes, and group lectures for cancer patients and caregivers. And then lastly, we have Jordan Hunter, who's our genetic counselor. Jordan is a board-certified genetic counselor at the Helen S. Carlos High Risk Breast Clinic at Piedmont, Atlanta. Jordan attended the University of Georgia for her undergraduate degree and then received a Master of Science in Genetic Counseling from the University of Texas at Houston. She worked as a hereditary cancer genetic counselor in Texas until moving back to Georgia and joining the Piedmont Cancer Genetics Program in 2021. Jordan specializes in hereditary breast cancer and is interested in proactively reaching women to stay ahead of cancer risk in the family. So thank you for all of our panelists for coming. A couple other people I want to introduce in the audience. Just some members of the Dora Shaheen Breast Health Center, Jasmine Woods, who is the manager. Lucy Husseini, who is our breast nurse navigator at Dora Shaheen Breast Health Center. Lori Plummer, who is the nurse practitioner at the new Helen S. Carlos High Risk Breast Clinic. Our new physician who just joined Atlanta Breast Care, Dr. Michaela Moen. And another special guest, Dr. Courtney Pollard, who is a radiation oncology here at Piedmont. All right, so we will go ahead and get started. I'm going to start with some hot topic questions for Dr. Deal. If I have breast cancer, will I do better if I have a mastectomy? Oh, is it on?
Better? Okay. Short answer is no, but ultimately there are some patients that have to have a mastectomy for various reasons, but if you have the option of a mastectomy versus a lumpectomy, the long-term survival is actually exactly the same. And so that's from studies all the way back in the 70s. We know that people long-term will do the same. Basically, what we do to the breast doesn't change the risk of it coming back somewhere else, which thankfully in most of our patients is really low, but the surgery that we do to the breast doesn't change that. Initially, there was a bit of a recurrence difference between a mastectomy and a lumpectomy, but Dr. Pollard and his radiation oncology colleagues have come a long way in terms of their effectiveness. So nowadays, the risk of it coming back after a lumpectomy and a mastectomy are basically the same, especially for really small tumors. There's some data to support that a lumpectomy might even do better. So I think it really comes down to a personal decision and, you know, a little bit more in terms of what's going on from an imaging standpoint, but lots of great options.
Thank you. We hear that all the time. Everyone always just thinks mastectomy. That's the best, but thanks for that very thorough answer. Dr. Sinha, I have been hearing about a new drug on the radio, Enhertu. I won't try to say the other name. Can I get this drug if I'm HER2 1+?
Yeah, so the drug you're talking about is trastuzumab deruxtecan, or Enhertu.
They can't hear you.
So its initial approval was for HER2 3+ or FISH positive. And so last year at the American Cancer Society Oncology meeting, which is this big meeting that happens typically in July, where they have these pivotal trials and groundbreaking results presented, they presented the data for this particular drug in a low expressing HER2 positive tumor. So either 1+ or 2+ FISH negative. Usually in one of these plenary sessions, there's somewhere between 2,000 to 5,000 physicians. It's a lot of doctors under that roof. This was the first time that I actually saw a standing ovation for the results of this trial. Patients who had had up to somewhere between 2 to 8 to 9 lines of therapy actually had a significant response to this drug. So the FDA actually approved the drug at the time of the plenary session. So yes, this drug is approved right now for stage 4 HER2 low expressors, and there are ongoing trials looking at what if you don't express HER2 at all? And they're also looking at the drug, using it before surgery, after surgery for stages 1 to 3. So we'll see a lot of interesting data about trastuzumab deruxtecan.
Wow, thank you. But so right now it's only stage 4.
Right now, it's only stage 4, correct?
Got it. Okay. Dr. Ma, what are the types of reconstruction I can get if I have a mastectomy?
Well, there are 2 main categories of reconstruction. One is implant-based, device-based, and one is using your own tissue from your body. So depending on what your wishes are, your anatomy, what additional treatment you may or may not need, one or the other may be better for you. And that's, I could talk about it forever, but those are the 2 main types.
Okay. Dr. Cook, why is it important to get a mammogram?
That is a great question. It's important to get mammograms every year, and we say starting at age 40 for average risk women. And every year after that, women should get mammograms. And the reason is mammograms it's the best screening tool that we have. It has the highest sensitivity and specificity of detecting breast cancer, and it's important for you to come back every single year so we can detect small changes on your imaging and find cancers early. The goal of imaging for breast cancer screening is to save lives. It's very simple. So that's what we try to do. We do it every day. We see lots of women in the Dora Shaheen Breast Center.
Question to piggyback off of that. So if my cancer was found or not seen on mammogram, why do I still have to have a mammogram?
So again, it goes back to the inherent technology with mammography. Mammography is the best tool we have for screening. Sometimes women who have dense breasts, we may not see their cancer on mammograms, but we have other technology that we use in conjunction with the mammogram to find those small cancers. And that includes ultrasound and MRI.
Great. Thank you. All right, Shayna, what are the best foods to eat as a breast cancer survivor, and what foods should you limit?
Well, I'm going to make everybody really hungry. The best foods to eat are colorful foods. Think about variety and color. In fact, think about what you ate today. Have you had anything red or yellow or green? Really, really get a lot of color, because that's the way to get a lot of your antioxidants and your vitamins and your minerals. And interestingly enough, most of us shop in the grocery store and we get the same 10 things every time we shop. So it's very important as a survivor to make sure you're getting variety. Okay, don't get those same 10 bananas and spinach and blueberries every time. Think about variety. There's this little acronym I heard years ago, and I share it with a lot of my clients at the Cancer Wellness Center, G-BOMBS. G for greens, lots of variety of greens, not just one. B is berries. O is the onion or the garlic category. M is mushrooms. The other B is beans, and the S is spices and seasoning. So think about a variety of colorful foods. Now, what not to eat? That's not the fun stuff. I like talking about the fun part of food. What not to eat? High-fat red meats, fried foods, a lot of added sugar, a lot of processed, salted, cured meats. You should be limiting those, but then focusing on the colorful foods, the variety there.
I'll ask you another question. We love talking about food. How do you manage the added sugar intake when there is sugar in everything?
That's a great question. If I could figure that out, I would let you know. No, I'm kidding. Our bodies live on glucose, so it's not going to be able to pick and choose fuel for different cells. So when I'm talking to people, the main thing is you don't need to be afraid of the color and the variety, the fruit, right? The whole fruit, but really be a food label detective and look at the added sugar that's in lots of food. Now, the guidelines do say that added sugar for a lady survivor is about 25 grams or less. That's the guidelines, 25 grams or less. For men, it's about 30 grams. So it's not zero. And I really tell a lot of people, look at your food labels, make sure the first couple ingredients are not sugary ingredients. Remember, OS, anything with OS is sugar, fructose, high fructose corn syrup, maltose, sucrose. So make sure if it is a sugary treat that you want to have, that's lower in the ingredient list. And from a practical standpoint, make sure that your meals are very balanced, because if you have some good solid protein, complex carb, and some vegetables, typically your blood sugars are not going to do this whole up and down kind of thing. So then you're not going to have that hangry, like, I need some sugar right this second kind of attitude, because you'll balance out your blood sugars in your day. So that's very practical, just to look at what you're eating on a regular basis. Another thing is drink a lot of water. That helps. And then also just brush your teeth after you eat meals. And that sometimes kind of stops that desire to want something real sweet to kind of end a meal. And finally, it is important to have balance, but if you have a little sweet treat, enjoy it. Just practice mindful eating and actually enjoy it.
Got it. Eat the rainbow and G-bombs. Okay. All right, Jordan, is genetic testing just for the BRCA1 and 2 genes?
So when we first started doing genetic testing, we first discovered the BRCA1, BRCA2 genes, and we're these days seeing women back that maybe had genetic testing 10 years ago for those 2 genes only. And there are maybe 10, 20 other breast cancer genes we can test for at this time, ATM, CHEK2, it's a bunch of alphabet soup. But our testing has become a lot more comprehensive over the years, not only for breast cancer genes, but also other cancers as well.
Cool. All right. We're going to jump back to Dr. Ma. So we talked a little bit about reconstruction, but what if I don't want implants? And I'm not a good candidate for a DIEP flap? Is there anything, or a latissimus flap, or any kind of those flaps you talked about briefly? Can I get anything else done?
For post-mastectomy?
Yes.
Yes, we can do an oncoplastic procedure, and what that means is we use whatever tissue is left over after mastectomy and kind of rearrange it so that it's a more pleasing form. So that would be a Goldilocks procedure if we have, if your breasts are large enough and there's enough tissue left behind, we can use the remaining tissue and create a little bit of a small breast mound. If not, there is something that's become very popular these days called the aesthetic flat closure. And that's more just sometimes after mastectomy, you see, like in the olden days, they had the amputation mastectomy where it's just a straight line oblique closure. This would just make everything a little more contoured and smooth and not a little more aesthetically pleasing, if you will. Yeah.
All right, Dr. Deal. How do you decide if I'm a candidate for a nipple-sparing mastectomy?
All right, so Dr. Ma will probably have her opinion on this as well because it's very important from a plastic surgery standpoint, but from a cancer standpoint, there's not really great guidelines. It's a little confusing still because nipple-sparing mastectomy is still considered relatively new, even though we have data for 15 and 20 years that says there's no higher risk of recurrence and it's safe. It hasn't yet made it into national cancer guidelines, and so there's not strict criteria in terms of what tumor size, the distance from the nipple that the cancer has to be in order to be eligible. So the way we practice in our group, at least, is we always take a margin from right behind the nipple areolar complex at the time of surgery, just to be on the safe side and make sure that we're not leaving any sort of abnormal or atypical cells right behind the nipple. If that comes back positive, we can always remove the nipple at a later date, but that is generally just ensuring that we're not leaving anything abnormal behind.
Anything more, Dr. Ma?
So I always tell my patients that there are 3 criteria that you have to meet in order to be a candidate for nipple sparing. Number 1, it has to be oncologically sound, so that would come from the breast surgeons. Number 2, the nipple has to be in the appropriate location on your breast, because if they're pointing to the ground, then saving it may not be the best option for you. And number 3 is that there is enough blood supply at the end of the case. Because the blood supply to the nipple and the breast tissue, or the breast skin, comes from 2 sources. One is the breast tissue underneath, which will be gone. So then the breast envelope in the nipple is now depending on the small layer of fat that is under your skin that provides the remainder of the blood blood supply. So if that is cut or manipulated in any manner where we would compromise the blood supply, then all that, the nipple and the skin, will die. So those are to me, the three main things that have to be met in order to be a candidate.
Okay. We'll switch over to radiology again. Dr. Cook, what is breast density and why does it matter?
So breast density is just a measure of how much glandular tissue is in a breast. So all women have a mix of glandular tissue and fatty tissue. And the density measurements just tells you how much you personally have as a patient. Density is important because it is an independent risk factor for breast cancer. So that is one of those things that will keep into your account for your individual personal risk. The other thing that it does is it sometimes makes cancers harder to see. So breast density shows up as white on a mammogram, and cancers will also show up as a white density as well. So sometimes it can make it harder to find, but we use 3D tomosynthesis imaging for mammography, which helps a lot for for patients with dense breasts. And there's also other supplemental screening tools we can use for breast density as well.
Cool. All right. Dr. Sinha, my friends are getting a test looking at tumor DNA in their blood. Can you tell me a little bit more about this test?
Yeah, so this is a question I get asked a lot. This is the liquid biopsy, right? So right now, and radiation oncology may disagree with me on this one, and we can hear Dr. Pollard's opinion on this. So there is liquid biopsy. So this is doing blood tests to look to see if you have circulating tumor DNA in your blood. And there's a couple of ways of doing this. One is you just take a blood tube and you look for a sort of a generic breast cancer tumor DNA. Something, there's lots of companies that are doing those. So Guardant 360 is one of them. There's another one called Signatera, which matches takes your biopsy that you had done, could be from 2 years ago, 5 years ago, extracts the DNA from that tumor, and then looks for the DNA in your blood. So you're matching the DNAs. In terms of breast cancer, let's say stages 1 to 3, patients have had chemo if they needed it, they've had their surgery, they've had radiation. Patient comes to me and says, can you draw this test for me? So a couple of concerns we have. Number one, it can be expensive. Out of pocket, if insurance does not cover it, it's probably somewhere between $2,000 to $3,000 a test. The second is, let's say we get a result that shows an individual has cancer cells circulating in their blood. The question becomes, what do you do with that data? We can do a scan. The scan does not show a breast mass. It doesn't show liver lesions. It shows clear lungs. The time from that positive result to the actual development of a true breast mass or stage, another lesion can be anywhere from a few months to several years. So now you're left with the anxiety of, I have this test that came back positive. Is it a false positive? And then what do we do in the interim between having a positive result and something actually showing up on a scan? It's hard to give chemotherapy to someone based on tumor cells that may or may not be circulating. The data right now for triple negative, so if you're ER, PR, HER2 positive, the lag period may be as long as 8 to 9 months. That is on average. ER, PR positive, it could be 2 years before something actually shows up on a scan, or we find something truly there that's actually measurable. So not ready for prime time, but I think we'll hear more and more about liquid biopsies.
Dr. Pollard, do you want to add anything to that?
I'll just say that I agree. I think we run the risk of, when we use data like that, that's preliminary, we run the risk of over-treating women, and certainly we don't want to give more treatment than we need and potentially make a lot of people really sick for no real benefit. So, like Dr. Sinha said, not ready for prime time.
Great. Jordan, who is eligible for genetic testing?
So when we meet with people to draw out family histories, we're looking not only for breast cancer, but also other cancer types, so pancreatic, ovarian, colon cancers. Anyone with a breast cancer diagnosis 50 or under is automatically going to qualify you. And insurance coverage, national guidelines for genetic testing. If we have rare cancer types in a family, ovarian, pancreatic, a male breast cancer, that's also something that could qualify. But we're really encouraging people, if you have questions or interested in genetics, talk to your doctor, meet with a genetic counselor. Self-pay cost for genetic testing is $250, and insurance is getting a lot better at covering testing in families that may not meet that strict kind of checkbox criteria that I just went through.
So follow-up question, if genetic testing is negative in the family, does this mean I am not at risk for breast cancer?
So really only about 5 to 10% of all breast cancer diagnoses have a genetic component, so an identifiable genetic mutation like BRCA. But we're seeing, another 10, 20% of families where we see this clustering or pattern of cancer in a family. We don't have a genetic component that's telling us why, but we don't think your risk is probably as low as general population risk. So at the high-risk breast clinic, we're seeing patients, either they had genetic testing or their mom had genetic testing, and we can still talk about, is getting your mammogram once a year exactly what you need, or should we be doing a little bit extra, an ultrasound or an MRI, something extra to stay on top of that risk.
Thank you. Shayna, we get this question all the time. Can a breast cancer survivor eat soy? And can we drink alcohol?
Yeah, I get those questions all the time too. Let me start by saying soy is not all created equal. And just be fully aware that a whole soy food, whereas it might be organic tofu in a dish, occasionally is fine, or edamame at a restaurant, or tempeh. I think in the context of a whole healthy plan, if you're trying to cut out high-fat meats and you have a little bit of soy occasionally is fine. A lot of the research, at least the new stuff that I've seen, it goes back to did a lady eat soy during puberty? That's showing the most health benefits. So when I'm talking to somebody, we're looking at their lifestyle and their pattern of eating over time. It's not just, oh, am I going to eat this one soy food one time? I mean, that's not going to be a big deal. Now, the reason I said all soy is not created equal is because there's a lot of that fake soy protein powder out there now. In soy drinks, in supplements, in powders that go into a lot of things. So really, really read your labels and make sure that you're not doing a lot of that soy protein powder, because you got to be a little leery with that. That's not going to give you, the whole soy food. It is a complete protein. It has all 9 essential amino acids. It is a plant-based protein. But a protein, a soy protein powder that's kind of powdered, we don't know how much of the phytoestrogens in it or how much of the isoflavones are really in it. So not all soy is created equal there. Alcohol. There are links between alcohol and breast cancer. There are. With that said, from what I've seen in research, it is not the one glass of wine or the one drink that you're going to have occasionally. In fact, the recommendation for ladies is 1 drink and men is 2 drinks. The question is how much, the serving size, right? If we pour half of the bottle into a goblet this big and we say I had my 1 glass, that's a little bit too much. So you just need to be mindful of how much, because there are risks, there are links. Alcohol has a lot of sugar. It sometimes causes us to eat unhealthy foods or miss a workout or not get our restorative sleep, which is so important for our immune system. So I think it's important to look at the whole picture. It's not the one cocktail that you're going to have at the end of this talk. I don't think you have to worry about that. But it's looking at the whole picture of your lifestyle and your patterns. I had a lady recently that was very concerned about that question, and you know what? It was off the table by the time we were done talking, because there were so many other good things that we could talk about food-wise and exercise-wise that can help prevent recurrence, rather than her 1 glass of wine that she had occasionally.
Great, thank you. Dr. Deal. My mother had breast cancer. Should I have a prophylactic mastectomy?
So not necessarily. I think that ends up being kind of a team approach because there's lots of other people on this panel that would be involved as well. You know, we want to make sure that your genetic testing comes back and is not positive. But to be honest, even if your genetic testing is positive, our radiology colleagues are so good. We have such great screening tests that it's never really a requirement that you have prophylactic surgery. We have options like mammograms, MRIs used on an alternating basis that are designed to really pick up an early cancer very, very well. So ultimately, even patients with BRCA mutations don't have to have surgery. That being said, all of those screening tests can add up, and it can be very stressful. So sometimes, from a mental health standpoint, the surgery becomes, the easier option. Reconstruction is covered by insurance, and even just a slight family history, sometimes insurance will cover the surgery. So there are options, but it's something that you need to come into the office, and we do a full evaluation. We figure out your risk based on not just your family, but you as well, your breast density, and we go from there.
Great, thank you. Dr. Ma, and this is also going to get some answers from Dr. Pollard too. What is the impact of radiation on reconstruction and healing?
Well, radiation, I tell people, is a necessary evil. All right. So if your choice is lumpectomy, then the whole treatment of the breast requires radiation. Except for in certain DCIS patients, I think. You have the Decision RT test. Exactly. So as far as its effects on the breast tissue, after lumpectomy, I find that people generally do very well. The breast tissue may shrink some over time. The radiated side is a little more lifted, a little more perky than the non-radiated side because it doesn't droop. Some people come in and tell me that they wish they could have the non-radiated side radiated, to be even. As far as on after post-mastectomy, implant-based reconstruction isn't the best option for post-mastectomy radiation because the implants tend to get hard. It forms unhealthy scar tissue around the implants. So that doesn't mean that implant-based reconstruction is not an option. Technically, these days we're doing a lot of what we call prepectoral reconstruction, meaning we put the expanders or the implants in front of the muscle instead of behind the muscle. It used to be that the radiation on the implants behind the muscle tend to get a lot harder because the muscles would contract a lot. The ones that are placed in front of the muscle tend to fare a little better. We have been wrapping them in some acellular dermal matrix that kinds of help protect it against the radiation changes. That in some people, their breasts feel fine, maybe a little firmer, a little perkier, but they're fine with it. Some people do get severe contraction that's very painful and uncomfortable, in which case we would recommend some element of autologous reconstruction. And that would mean some tissue from your own body, either replaced with tissue from your abdomen, where we can use it as a free flap and use your belly fat to make a breast, or we can use your muscle from your back, rotate that around on its blood supply, and that blood supply will help basically nourish the poor radiated skin and kind of like make it healthy again, protect against the implant contracture.
Wonderful answer by Dr. Ma. I can't argue with any of that. Radiation is fairly toxic to the skin, and there's a number of acute side effects. Those folks who participate in rigorous skincare regimens after completion of radiation tend to have a better result. And what I mean by that is you're applying a layer of moisturization to your skin once or twice a day, and as part of a daily routine, it does two things. One is it helps moisturize the skin. We kind of dry out the sweat glands, so your skin just isn't as moist on the radiated side, so it helps kind of keep the skin healthy. But then it also helps when you massage, you're kind of waking up the nerves and waking up the muscles, getting good lymphatic flow, getting good blood flow back to the tissue. So those folks tend to do a little bit better. It's interesting, just kind of as an aside, what I've noticed and what we as radiation oncologists notice is that there is a difference between skin recovery and how much melanin you have in your skin. It turns out that fair skinned individuals tend to recover their skin color a lot quicker and easier than darker skinned individuals. We still don't really know why that is, but we see it almost on a routine basis. Just a little aside.
Thank you. Dr. Sinha, another question. I was taking a hormone blocker for 5 years, but now my doctor says I have to take it for another 5 years. Which patient should take it for 5 versus 10 years?
Yeah. So this concept of extended duration hormone blocker or endocrine therapy, so tamoxifen, anastrozole, exemestane, this is a very new concept. So I have patients that I may have started endocrine therapy 2018, they're about to finish. And so there is data out there that is suggesting that women with sort of higher risk disease, and by that, and it's very individualized. So patients who are tolerating it well, node positive, and maybe large tumors or large tumors, we are trying to tease out the endocrine therapy for longer. There was a study published last month that said 7 years is actually as good as 10 years. So 10 years is really no better than 7. So somewhere between 5 and 10 years for large tumors and or node positive. In your small tumors, node negative, 5 years is probably sufficient. There are some tools that you can use if we're really unsure, something called the breast cancer index, which is pulling out your tumor from 3-4 years ago and looking at some genomic studies on that will maybe help us decide if patients should take 5 years or longer. But that's really for patients tamoxifen, node negative to 1 to 3 nodes. So again, very individualized, and also how patients are tolerating it.
Does age play a factor?
Actually, no, it does not. So even in my younger 35-year-old breast cancer patient who had a small tumor, we're not saying you should take it for 10 years.
Very good, very good. I know in the back we had some cards for if anyone in the audience had questions, or if anyone has a question, you can raise your hand and Dr. Moen will come around with the microphone. If not, we'll keep going. Yep, question.
Hello. What about salt and oil? How does that, this is for Shana, how does that factor into your diet?
Well, you can eat salt, okay? Depends on your blood pressure. Everybody needs to watch the amount of salt they eat, but you don't need to avoid salt by all means. And oils. A lot of the research, at least with breast cancer, is in extra virgin olive oil being one of the healthiest oils. It has monounsaturated fat and polyunsaturated fat. So it acts more like with its health benefits, anti-inflammatory health benefits, basically. So you can't cook with that at high temperatures, so then we usually recommend more of just your olive oil or your coconut oil sometimes. But you do have to be careful, you're right, you do need to be careful with using a lot of oil in your food, because ultimately you want to have good weight management. And so if you are dealing with that, you don't want to use a ton of oil, but hands down with breast cancer, extra virgin olive oil has a lot of good health benefits.
Question in the back? Or I see a couple in the back and then one in the front. There.
I think this is for Mr. Bauman.
Me? For Dr. Bowman?
Miss Aaron?
Yeah.
Are you the, I'm trying to, okay. Does breast implants cause breast cancer?
I think this is for Dr. Ma.
No.
She's a plastic surgeon. She knows all about breast implants.
That's what I was looking for. Okay.
Right up front here.
Hello. I had a question about the incidence of breast cancer in women under 40. Has there been an increased incidence over the years based on your experience, based on the studies? For me personally, I'm 34 years old with breast cancer, and I don't know if I was moderate risk. I would consider myself moderate risk, but did not have a mammogram planned until 40. So how would you advise women that are under 40 to, I guess, screen themselves?
So we have been seeing breast cancer in women younger and younger. And actually, the American College of Radiology just updated their recommendation that every woman starting at age 30 should have a risk assessment. So that means talking to your doctor, get your individual risk. Perhaps going to see genetics might be appropriate for you. But depending on your individual risk, then you might qualify for screening earlier. But that's a new recommendation from the ACR because of the increased incidence of breast cancer in younger patients.
How does that line up with the recommendation of seeing an OBGYN less frequently?
I'm not sure what the recommendation is as far as OBGYN visits.
I think it's every 2 years. It's every 2 years.
Okay.
Oh, you don't have to answer. Someone else can answer. But yeah, that was my question. If we're only going to see, for example, I had my daughter 6 years ago, and I'm not having a follow-up or seeing my OBGYN except for every 3 years now. So being under 30 and not seeing them annually, do they get a breast exam every 3 years, under 40? How does that work out? What would be the recommendation, I guess?
So I treat a fair amount of GYN malignancies as well, and I think that's a fantastic question, actually. The difference is, and why you can space out the GYN exams, is that cancer is a lot less frequent in the population. Cervical cancer is a relatively rare cancer that a lot of times we're catching before it becomes full-blown cervical cancer with pap smears, but the incidence is just not that high, so you don't need to test as frequently as you do with breast cancer, which is a lot more common. Endometrial cancer is a lot more common than cervical cancer, but it's not a disease of young women on the whole. Obviously, young women can get it, but it's usually they don't. Does that answer it? Ish. Okay.
I'm a 25-year breast cancer survivor, and I'm curious if you still use the Sentinel. Trust me, that was my gift from God. I'm curious if you still use the Sentinel node test, and can you describe it for people?
Yeah, absolutely. So Sentinel node is actually something that was described in the early 90s. It was kind of this brilliant idea where we injected some things into the breast and gave a massage, and those things recreate the pathway that the cancer would have taken if it was trying to spread to the lymph nodes in the armpit, which is generally the first place that the cancer likes to spread. Just because the things accumulate doesn't mean that there's cancer there. It just means it's the first place and the nodes that we need to check. Interestingly, we definitely still use it, routine part of our practice. We're kind of looking at people that maybe don't necessarily need it anymore. So the armpit incision, I personally haven't had breast surgery, but I think most of our patients would say that the armpit incision is probably more bothersome than the breast incision. So we are starting to look to see if there are patients that maybe don't need us to dig in their armpit. But certainly it's still a mainstay of our practice, absolutely. And it's nice because if it hasn't made it to the lymph nodes, then we generally assume it hasn't made it anywhere else. So we don't have to get whole body pictures or things like that if it hasn't made it to the lymph nodes.
And then just to add on to that, as breast techniques, treatments are evolving, we also have a new injection called MagTrace that we just got approved to come to Piedmont. It is an injection that we can use. We can inject at the time of surgery. It lasts in the body for 28 days, so we can actually get the final pathology back first and determine if we need to go back and do a sentinel node biopsy based off of that final pathology. So we can potentially save people from having that risk of lymphedema or also the pain that's associated with the sentinel node biopsy if they don't need to have it.
They removed mine through the breast tissue, so I did not have to have the arm done. The second question I think is probably for Dr. Ma. At one time I remember that they would say, I'm sorry, that when you had reconstruction, if you had body reconstruction using your own fat, and you only did it in one breast, you could not do it in the other breast. Has that changed at all?
No, that's the same. So when we're doing reconstruction using your abdominal fat, normally we would use, if we're doing bilateral procedure, we'd use half of your abdomen for one breast and half for the other. But if we're only doing one side, we don't leave the other half of the abdomen. So we just excise and discard that tissue. So once that tissue's gone, the vessels to that area is gone. Even if you think you've grown more fat in the area, you're no longer a candidate for that procedure.
Another question?
So yes, this question is for you, Dr. Bowman.
Okay.
So that sentinel node fluid that you just talked about,
The MagTrace?
yes, is
Yes.
that available like right now?
Right now.
Oh, yay, yay.
Prime time.
Okay. And then the other question is, what's the criteria for having no chemotherapy and no radiation?
That's a
Yeah. So
a big there's a lot more information I think we probably need to have to say no chemo, no radiation, because treatment involves all three modalities, right? Surgery, radiation, and medical treatment. So there's,
yeah.
Dr.
it's-
Sinha, do you want to?
Yeah, so, pre-invasive ductal carcinoma in situ that you've had a double mastectomy will not need chemo or radiation. That may be one, but it's very individualized. So maybe a very small tumor may not need chemo. 1 to 3 nodes, even if you have them, may not need chemo. You may still need radiation for both those scenarios. So it's a very individualized. I think I wouldn't say that here's 5 criteria. I think the age of the patient, the node, the size of the tumor, the ER/PR positivity, lumpectomy versus mastectomy, all of those sort of categories will play into whether a patient needs chemotherapy or not, and then radiation or not.
Thank you.
This question is for Shana. So Shana, you mentioned when you were talking about soy, that you would check whether or not the person
Can you hear?
ate soy during puberty.
Can you speak closer into the microphone? We're having a hard time.
Okay, can you hear me now?
Yeah, perfect.
Okay, so you mentioned soy during puberty. So why would you check for that? That sounded interesting. I just wanted you to elaborate on that.
Well, a lot of the research that I have read just looked at the lifespan of somebody, and there were a lot of changes in your body, a lot of hormone changes at puberty. And so it was showing, when I read the research, it was showing that interesting that when somebody started doing whole soy food at that point, so for instance, you have a kiddo and you serve them tofu sometimes, or you do a little bit of soy milk, it's showing a lot of benefits in preventing breast cancer.
Question up front?
Bernice. I can't help but take this opportunity. I'm Bernice Cohen, and I'm a physical therapist, breast cancer rehab. So, trick question: is it important to get breast cancer rehab when you're going through all the process? Yes.
You can answer your own question.
I'm answering my own question. Yes. Thank you. So, I'm here at Piedmont. If anyone has any questions or needs to come see me, I'm part of the team.
But yes, the answer is yes.
An essential part of the team.
Essential. We need a microphone, Dr. Pollard.
I was just giving kudos to Bernice and her team. They are truly fantastic. And they do significant work in getting folks who have late effects from radiation, like fibrosis, skin tightening, functional, very functional. And the folks come back who could barely lift their shoulder past 90 degrees, throwing, with their children. It's pretty awesome. So thank you, Bernice.
One question over here.
I don't really have a question. I just wanted to say that I saw Bernice and I couldn't lift my arm. I mean, and Dr. Deal sent me to Bernice. And Dr. Deal also, I don't have a scar under my arm and he had to take out 9 nodes. But so anyway, thank you, Dr. Deal. But I went to Bernice. I couldn't lift my arm. And look, I can lift my arm up now. And and Shana Komar does nutrition classes for people that have had cancer, and they're just the best thing. I just love it, and I've changed what I'm eating because of that. And so if anybody has had cancer and would like to learn how to prepare foods better, I highly recommend it.
Yeah.
Thank you, Louise. You are wonderful. Louise is talking about our Piedmont Cancer Wellness Center, which is fabulous. We have in-person classes, but we also have virtual. So since COVID, we kind of do a hybrid now, which a lot of people like that model. So we have a calendar, full-blown classes, either in person or virtually. And she was specifically talking about our cooking demos, where we couple myself with local chefs, and you get to taste all the food. It's free. You can bring a caregiver with you, and you learn, you have fun, and you get really inspired with good, healthy cooking for survivorship.
So excited to see that back. That's awesome. I don't know where we are on time. We have one question. We'll take a few more questions, and then we'll all be around in the back in the cocktail reception, so we'll be able to do some one-on-one conversations too. Dr. Moen right up front here.
All right, as a breast nurse navigator at the Dor Shaheen Breast Center, I get this question asked a lot prior to their biopsy. They say, if I get a biopsy, will that spread the cancer because you're poking at it?
So the short answer to that question is no. It does not spread the tumor. It's one of those, breast cancer is one of those cancers that does not do that. There are other types that have that risk, but breast cancer is not shown to be one of those.
And then follow-up question, another question that I get asked or commented on, thermogram versus mammogram. I don't want the radiation.
So a thermogram is not an FDA-approved, don't even want to call it a test. It's not even an FDA-approved test for breast cancer screening. It is not a tool that is approved or has shown any benefit for breast cancer screening. The only tool that we have is the best tool that we have, which is mammograms.
Radiation exposure from a mammogram is 0.4 millisieverts, and you get 3 millisieverts just from walking around in the world every year. So it's pretty well tolerated.
And eating bananas.
And then one more, and this is it. Okay, so breast MRI. I don't want to get the mammogram or the ultrasound, I just want the breast MRI. Can that detect cancer?
Two great questions, Lucy. So breast MRI is a great test. It's not recommended for everybody. It is a very sensitive but not specific test, which means that there are a lot of false positives that come from MRI. So we reserve MRI for patients who are high risk, and that could include a genetic risk. It can also include patients who have had breast cancer, and they're high risk because of their prior history. Sometimes we recommend it for some imaging findings, but generally speaking, I know I'm saying the same thing over and over again, but that's because it's important. Mammograms are really the best tool for screening.
Good. Well, one more question. This will be our last question. Panelists, I'm going to ask you for any final tidbits.
This question is about tamoxifen. What if I don't tolerate tamoxifen? What if it makes me feel terrible and I don't want to do it anymore? That's just what people say.
No,
So
you're right.
What happens after that?
Patients will say that all the time. So for invasive breast cancer, the dose is 20 milligrams a day. There is data out there for pre-invasive breast cancer, so DCIS, atypical lobular hyperplasia, so these pre-invasive for a 10 milligram every other day, based on a European study. It depends on what the side effect is. So there are natural products that we can use to combat some of the side effects of tamoxifen. So hot flashes, vitamin E, evening primrose oil, Relazin. Some of our patients work closely with the Wellness Center, Mr. Hobbs, who sort of allows sort of a naturopathic integration with tamoxifen. Even some of the prescription, we've also used prescription medicine. So obviously there's natural products, but things like Effexor that can help combat some of the side effects, the mood irritability or the hot flashes. Gabapentin can help too. So there's definitely things that we can do to really try and keep you on tamoxifen. If tamoxifen is really affecting your quality of life despite doing some of those things, then another option for some patients is to use one of the postmenopausal pills, so the pills that are approved for patients who have gone through menopause. But that then requires us to make patients menopausal. So you're sort of exchanging one for the other, and some patients tolerate the option 2 better, and most patients will, with additional medication, tolerate tamoxifen fine.
Any final tidbits, closing comments from our panelists? No? Well, I would like to thank everyone for coming. Thank our panelists, our panel of experts, for taking time. They're all very busy, and I want to thank you for taking your time to share your information, your knowledge here today. Again, thank you to the Women's Auxiliary for putting this event together. We're so grateful. We know October is Breast Cancer Awareness Month. We practice it every day, and we want you to also, not just this month, but every day, stay vigilant about your breast health. So thank you again for coming. And we will join you in the back.